Produced by Kurious Arts.
Hello and welcome to A Curious Conversation. This is the second in a series of broadcasts in the run-up to the season of debate. You can find us on Facebook at Kurious Arts, on Twitter at ArtsCurious, on Instagram at Curious_Arts, and by searching for www.curious.art. My name is Alex Mellor, and I'll be having a chat with my peers about their work in university. With me is none other than Ratnu Vaidya. Welcome to you.
Thank you very much for having me on.
Thank you for coming down. So, tell us a little bit about yourself. Who
So,
are you? Go on.
I'm Ratnu. I am a fourth year medical student at Newcastle University.
Lovely.
I'm quite interested in medical leadership, intellectual disability, and one of the areas that I'm passionate about is the role of carers in the NHS.
Lovely. So, you've done quite a lot of work. You've really thrown yourself into this field, not just for your university work, but also some initiatives, so to say. So would you like to tell us a little bit about them? The first one being STOMP, of all things.
So in my third year, I started to get involved with research, particularly research around intellectual disability and autism. Right. One of the initiatives that's come out of NHS England is something called STOMP.
Yep.
Which, in terms of sort of medical acronyms, it stands for Stopping the Over-Medicalisation of People with Autism, a Learning Disability, or Both.
That is quite the mouthful, and I'm glad we've got a little acronym for that. So, the thing that's jumping out at me in there is the OM, the over-medicalisation part of that.
Yeah.
Tell me a little bit more about that.
So, often people with learning disabilities or with autism can exhibit challenging behaviour. Mm-hmm. Because they can't communicate as you or I would.
Yes.
Their behaviour is a means of communicating instead of their words might be.
Right.
Which means that, say, for example, if somebody's distressed, if somebody's upset, there's the chance that they can have behaviour which can be perceived as aggressive.
I see. Okay.
As a result of that, it means that the care providers and people looking after them want a means of effectively calming them down.
I see. Okay.
You know, people with quite complex needs can be given antipsychotics or benzodiazepines as a form of sedation.
Things that may not be suitable for them.
Exactly. So it may be suitable in order to get them to calm down for that sort of initial point. But long term... You're
addressing the symptoms, not the causes.
Exactly. Because you're not addressing why somebody's actually feeling distressed in the first place.
Right.
So what the STOMP initiative does is it's essentially highlighting to clinicians, highlighting to doctors, nurses, GPs, etc., trying to look at what psychotropic medication are these people prescribed and why they prescribed it. Mm-hmm. My role within that specifically is looking at the prescriptions that are given to clients within inpatient units in the Northeast. So it's identifying what medication have they been prescribed, what's the rationale, why have they been prescribed it, and if they have been prescribed it inappropriately, what are the structural and policy changes that can be done differently to make sure that these patients ultimately are being given medication only when they really need it.
I see. So no one's, in truth, no one's really at fault with these things. When you talk about looking into things, there's a tendency for it to come off as quite, we're trying to find someone to blame. There's no one really to blame in all of these issues. It's just a misunderstanding. Is that the right way of putting it? Or
so you're right. There isn't really anyone to blame. But the whole idea being that ultimately the health service is quite stretched.
Yes,
and people don't have as much time to spend with their clients. With people with autism, with learning disabilities as they may like. Oh,
so this is one way that it may just be easier to say, here is something like say, antipsychotics. Again, something that may not be suitable in the long term, but is a quick fix.
Yeah, exactly. And the issue is if these patients are on them for years and years and years.
It could have, all sorts of side effects.
Yeah, with any drug there are side effects, particularly so with mental health drugs.
Wow. And all of this in your fourth year of university?
So, I mean, I've been working on it since I was in third year.
Wow, yeah.
So obviously it's something which is taking up some of my free time. But I think ultimately it's worthwhile and it's important to have the information, have that data to better influence policy.
I see. Okay, so you're in your, you say you're talking about different years of university. Tell us a little bit more about that. Like say you're at Newcastle studying medicine, and there's a lot of, let's say, mystique about going to university and studying medicine. Again, you're in there for 5 years compared to a normal 3. Like, what's that like? There's like I say, lots of rumours, lots of just stories, I guess. Can you confirm any of these rumours, anything like that about medical school and university?
Well, unfortunately, it's not quite like House, and it's not quite like Scrubs. I think you go in with the expectation that, you know, you'll be on the wards 24/7. You'll be like handling crisis patients, really quite baptism by fire.
Yeah, crash carts, the whole 9 yards.
But in reality, people tend to learn best through a variety of different ways.
I see, okay.
So our first couple of years aren't that clinical. We spend it in lectures, we spend it in seminars and tutorials, learning more about the human body and how it works. There's no point trying to rush and jump straight into a hospital when really you have no clue. But towards the sort of later end of the course, we have more clinical time. We're pretty much on the wards 9 to 5, Monday to Friday, in GP surgery, seeing what life really is like on the shop front.
That's the only way to really do it. But like say, first year, you're not really, you know, carving people open and probing around inside chest cavities and all that sort of stuff.
Far from it.
Okay, so again, with university, there's something that you brought up to me, and it's specifically carers within the NHS.
Yeah.
And you shared with me a BBC News segment about clinicians as carers specifically, which again will be linked in the description and in the show notes. So tell me a little bit about that, because again, your father, of all people, featured quite heavily on this as well. So can you tell me a little bit about that?
Sure. So when we think of somebody that's a carer, the first thing that springs to mind is perhaps the elderly woman who's looking after her husband who has Alzheimer's, the husband that's caring for the wife with a mental illness.
I see.
But one of the things that doesn't really come across is the fact that carers can be anyone. Caring is such a leveler, because almost everybody will experience some sort of difficulty or health issue in their life. And unfortunately, for some people, that means they're not able to fully look after themselves anymore.
I see.
Particularly with an aging population, we have people that are getting older and tend to become more dependent on others for basic self-care. The reason why we got involved in this was because both of my parents work in the NHS, but my younger brother has quite severe learning disabilities.
Right.
Which means that there's that combination role. First and foremost, you're seeing patients on the shop floor.
Yes.
But at the same time, you're caring inside the home as well. Which means that fundamentally, there's no sort of off switch.
Yeah, there's no barrier. Your work life and your personal life, so your home life, will bleed together.
Yeah.
Wow.
I think that's one of the reasons why I'm actually interested in intellectual disability in the first place, trying to improve the lives of people with special needs.
I see. So again, this specifically, it's the carers within the NHS.
Yeah.
So talk to me about this. Again, the thing that I'm struggling to wrap my head around is it's the why is this? If we've got carers at home, you know, do we just not have the resources and the ability to look after them within said institutions? Is it easier to look after people at home and to model sort of home life and that sort of personal life around these sorts of things, or would we be better off in an institution or dedicated place of care?
So most of the time people will much prefer to be at home. They're in an environment where people know them very well, they love them, and they are devoted to them. And fundamentally, institutions are seen as a relic and a thing of the past.
I see.
We're moving away from more care in institutions, and we're shifting more towards care in the community.
Oh, okay.
Ultimately, people with special needs will tend to do better surrounded by the people they love and in an environment that they're familiar with.
I get you now.
But the key thing about carers in the NHS is that as a population, carers are vastly overrepresented. If we think in terms of the general UK population, about 1 in 7, 1 in 8 could be classed as a carer.
Wow, that broad.
Yeah, exactly. It could be your bus driver, your teacher, people that you walk past in the street. They will more likely have a caring role at home as well.
A bit like, say, this could be anything from as simple as, you know, an elderly relative all the way to a relative or a person you care about with a learning difficulty.
Absolutely.
I suppose that's probably why it's such a broad title, I suppose.
Yeah.
But please go on.
But the thing about NHS staff is that they're actually overrepresented in that population. If we think about 1 in 7 in terms of the UK population, about 1 in 5 NHS staff could be classed as a carer.
Okay.
Which means that you're both caring inside the workplace and caring outside the workplace as well. So
talk to me about this. So you say 1 in 5 NHS workers are also carers.
Yeah.
That, like say, there's no off switch, there's no barrier. That must be an immense strain, an immense pressure. You know, you talk about doctors and nurses working insane hours on the ward, but then have to go home and, like say, not switch off.
Yeah, exactly. For some, it can be quite a big motivator. So for instance, the care role that I had before leaving for university. It inspired me to learn more, and it's why I'm taking part in the research that I'm doing.
Oh, I see. Okay.
But at the same time, it can be quite stressful. Not only are you dealing with quite high-risk patients at work, quite literally life or death situations, but you come home to that as well. There's a risk of stress, there's a risk of burnout. People take long-term sick leave. And ultimately, that's detrimental not only to the people working in the health service, but to the health service as a whole.
I see. So while you may have the skills and the appropriate training to help look after someone at home, with that professional level, like say, if you're not getting your sleep, you're coming into work and like say, it's a big risk.
Absolutely. It's untenable over a long course of time because there's no off switch, because you're constantly looking after somebody one way or another. It means that people can be quite prone to stress, to burnout, all of these things. And this knock-on effect means that if they take sick leave, for instance, that means the NHS has lost a doctor, a nurse, somebody working there, as they, take time off to recharge. Okay.
So you mentioned about care within the community. And that's wanted me to ask the question, what can be done to support these carers?
So support comes from lots of different ways. It can be as simple as having respite care.
Okay.
Where the person that they're caring for spends a night a week, 2 nights a week somewhere else, just to sort of give the person caring for them a bit of a break.
Yes.
There's also ways that employers can change in terms of more flexible working. Say, for instance, if you are caring for somebody with terminal cancer, for instance, and they need to attend an urgent hospital appointment, it's good to have that employer level of flexibility, which means that you can say to your boss, I can't come in this afternoon, I have to take so-and-so to an appointment.
Yes.
And that is something which is important to sort of push and promote, particularly towards NHS employers.
Yes. Okay. And again, that takes my next question. Like, well, what can the general public do as a whole? So, like, I assume if you know somebody who is in this caring role, like, say, you can offer them respite care. So, I can help here and there. But also, like, what can the general public do you think?
So the role for the general public can be as simple as perhaps making a cup of tea.
Really?
If someone's feeling stressed and if someone's feeling a bit low, particularly if they've got challenging things going on at home as well as challenging things going on at work, just really simple things like that can be a step. Secondly, it's having conversations, actually normalising the fact that somebody is caring outside of their job as well.
Okay.
There's often some stigma associated with having a caring role. Employers might think,
I do have to stop you there. A stigma with the caring role, that can't be real, right? Especially not within the NHS itself. I mean, aren't you all carers by definition, or?
I think that there's a distinction between when you view somebody as a professional working and when you see them as a carer role at home. Often people can feel that these staff may not be able to contribute fully to their job.
Oh, if their mind's in two separate places.
Yeah, exactly.
Wow.
And if their commitments are shifted between two different places as well.
Again, it takes you back, like you say, it's detrimental if you've got if you're overworked at home as well as at work.
Exactly. So people often don't feel confident in sharing, this is what I do at home. Wow. These are the challenging circumstances which I am faced in. But at the same time, there's often a sense of pride that comes from caring.
Oh, I can imagine. You're doing something that's noble.
There's a sense of duty and a sense of responsibility that comes from looking after somebody that you love.
Yes.
And one of the things that I'm quite keen to advocate for is saying that essentially if you're doing this at home as well, you have so many more skills, you have so much more personal experience, which you can then apply to your job.
Yes.
Think about it. If you're looking after somebody who has special needs at home and then you go into work and look after somebody with special needs there, you can take your skills, you can take your personal experience and then apply it to your job to get better outcomes and ultimately happier patients.
Oh, wow. Always turning a negative into a positive there.
Absolutely. These people are such a wonderful resource, and it's important that we advocate for them as much as possible.
I see. That is quite a... you hit the nail on the head there. So, to kind of swing away from STOMP and unpaid carers, I'd like to ask you, what do you think are some of the challenges facing the youth of today, specifically of our generation, our age bracket?
Oh, I'm getting on for days about this.
Well, we haven't got days, but however long you want.
there's obviously things like the job market, the housing market. House prices are going up disproportionately high compared to wages.
Yeah.
It can be quite difficult to find a job that's well paying.
Well, I suppose there'll always be a need for doctors and carers.
Yeah. Carers and unpaid carers are by their name unpaid.
Well, yeah.
But doctors, there's quite a big demand for them. But because of the stresses and increasing strains of medical practice, lots of foundation doctors aren't actually taking that leap and continuing on with hospital medicine.
Hang on. Sorry, you're in, when you say foundation doctors, that's your first 5 years, first 3 years, correct?
So it's the first 2 years after you graduate from medical school.
Wow. And then they're not taking that leap. That is, why is that?
There's lots of different factors. Often working conditions can be quite tricky.
Well, if you're 12 hours on the ward sort of thing, it's not, I've fortunately never had to go to an ER, but I've known people who have. It's not, I can understand that.
It's obviously quite a stressful environment, and the nature of medicine is shifting more towards sort of increased responsibility and more towards sort of people may not feel as supported as they did, say, 10, 20 years ago.
Really? So you say they might not feel that way as supported. Where's that sort of feeling come from? Is it, cut pay, less resources?
I think it's a combination of all those things. There's a really interesting survey that said that only 38% of Foundation 2 doctors after your second year of hospital medicine actually continue on and go into a training program. The rest may take breaks, may leave to go somewhere else. For example, Australia, New Zealand, or may pursue something else other than medicine.
Okay. So on that sort of note, when you talk about leaving university and as a challenge, what do you think will be the challenges, or have you experienced any of them yourself?
Thankfully, I'm quite insulated because I've got a couple more years left.
Oh, lovely.
At university.
What do you think's waiting for you right around the corner?
The joys of actually working in a hospital.
Oh, wow, yeah.
I think that we are trained so much for it. It would be a shame to sort of let that go. I don't think it's a challenge so much as opportunity when you leave medical school, because not only are you finally getting into the world of work, but you're also actually taking part in the thing that you've been training for and that you signed up for all those years ago. Wow. Which makes it all the more shocking that people actually want to leave in the first place.
So you mentioned the training. Tell me a little bit more tell me a little bit more about that. Again, I can only guess. What are the sort of things that they prepare you for? Well,
they prepare you for anything that you might encounter on the wards in A&E, in GP surgeries. Obviously, you can't account for every single possible medical condition that can come up.
I'm waiting for a but.
But you are trained to not only escalate care to consultants, specialist registrars, all those other people, but you're also trained in how to actually deal with quite challenging situations.
Yes.
Say, for instance, Newcastle is an exceptional medical school at teaching their doctors how to communicate with patients.
Yeah, because that's something that you talk about bedside manner.
Yeah.
And again, that's something that I suppose most people who are in those sorts of situations don't take into account how much that and how much training goes into that, and keeping yourself composed when people are screaming, people are panicking, people are stressed.
Yeah.
So I suppose there's a level of respect there and being able to compose yourself.
Yeah.
Can you tell me a little bit more of that sort of training?
Well, often you'll go through sort of scenarios, and you're assessed in these things called OSCEs.
Okay.
Which stands for Objective Structured Clinical Assessment.
Another one of those NHS acronyms.
Absolutely. This one's a worldwide one. But what you do is you are in a clinical encounter and you're assessed on it. Say, for example, you go into a station and a patient is complaining that their mother has had a fall on the ward and they want to talk to you about it.
Oh, wow. What
would you say to them? How would you do it? And how would you essentially reassure that patient?
Okay, so like say my mother's just fallen down on the ward and I want to talk to you. Like again, so is there a battle plan per se, and a steps to follow?
There's a structure. I wouldn't exactly call it a battle plan. That implies you're at war with your patients and their families. But you're very much on the same side. You're very much wanting to support them. Ultimately, it's about responding to what their needs are, understanding what their concerns are, and essentially getting the best outcomes for them.
I see. Okay, so I've got to ask, to take it back to the original topic, which was challenges exiting university. Do you have any advice for people who might be going through this, who might be maybe in your position of just about to come out of university. Maybe they've got a year and a half left, and they're looking down the barrel of facing these responsibilities.
I mean, if I'm in the same situation as them, I'm not sure the advice I'd give is particularly pertinent, given that I'm not actually left university yet. But I think one of the key sort of principles that guides me through is think about why you joined in the first place, and think about the patients on the end of it, the actual impact and the change you're going to bring about in their lives.
Is that quite common? Medical students who have had their decision to join medicine informed by their wanting to help people at the end of it,
Absolutely.
Their own personal experiences.
Absolutely. I mean, you wouldn't spend 5-6 years going through
just for the money. Yeah.
Unfortunately, the money isn't what people think it is.
I'm not going to even broach on that sort of topic, because that is it's a whole other rabbit hole. But wow. Okay, so let's finish on one thing as well. You got any good stories coming out of university? We're going to completely shift tone here. Any good stories?
I mean, none that are probably suitable for broadcasting.
Well, maybe nothing too awful, but maybe something a bit more uplifting. You talk about these experiences within hospitals, like success stories. There must, you always hear about, like, oh, this is so and so, and something horrible has happened to him, but he's got better. It's always like, yeah, you might have lost a leg, but now you can still walk on it. It's that sort of thing. Any success stories, I suppose.
Yeah, actually, there are a couple of patients that I've seen that really, really stick out to me.
Yeah.
One of the things which Newcastle does as a medical school is that they bring patients with lived experience of illnesses to do some of the teaching.
Wow, that must be absolutely invaluable.
Yeah, absolutely, because you're hearing it straight from the horse's mouth, as it were. One chap that really stuck out to me was a guy with quite debilitating MS, which is multiple sclerosis.
Yeah, I know about MS.
He was really quite unwell, but one of the highlights of his day was coming in to tell the medical students about it. We do neurological examinations on him.
Yes.
And the very act of him coming and sharing his condition with us and us learning from it, that was beneficial both ways. Not only does he feel listened to, does he feel supported, and not only does he feel it's actually having an impact on training the doctors of the next generation, we are also using such a valuable resource, which is the actual patients themselves.
Yes.
Learning from them and learning what we can do to help improve their lives.
I see. Wow. Well, thank you very much for coming on the podcast, and thank you very much for sharing that with me.
Thank you for having me.
Like I say, this has been a curious conversation with Ratnu Vaidya. I've been Alex Mellor, and you can find us on Facebook at Kurious Arts, on Twitter at Arts Kurious, at Instagram at Kurious_Arts, and by searching www.kurious.arts. Like I say, my name is Alex Mellor, and this has been a curious conversation. Thank you very much for coming on.